Hey Ashley, this is Marquez. Can you hear me?
Yeah, I can hear you.
Okay. I just want to make sure you can hear me. Hold on.
Okay.
Hold on a second, Ashley. I gotta do one more test. Hold on. Ashley, can you come on the video and then count to 10 for me?
One, two, three, four, five, six, seven, eight, nine, 10.
Did you get that, kiddo? Okay, thank you, Ashley.
Councilmember Nadeau, we're just waiting on one more colleague.
I am at your service.
Thank you. Oh, look, we have a friend.
The other markup just ended, so now we're here.
It's that time of year, isn't it?
Especially when one of those bills has to go through the markup that just ended and now in this one. So
Yeah, we couldn't start until they finished anyway, so
yeah.
It all works.
Councilmember Henderson, this is Marquez. I'm in room 123 with Parker staff. She said he should be about 5 minutes late.
Okay, we've got like 10 things on the agenda. So we're
Okay.
gonna start and then he can certainly join us when he joins. Was that it?
Okay.
I think
Thank you.
I think they communicated that, so I think we're good. But Marquez, are we good to start?
Good to start. Let me double check. Make
Okay.
sure. Good to start, Kenneth, in 123? Okay, the Councilmember Henderson is ready now, right?
Yes.
Yep, she's ready now. Yep, go ahead, Councilman.
Great. Thanks, Marquez. And good afternoon. I'd like to call this meeting to order. Today is Monday, November 18th, 2024. The time is 2:36 p.m. This is an additional meeting of the Committee on Health, and we are holding this meeting virtually. I'm at-large Councilmember Christina Henderson, Chair of the committee. We've been joined by Brianna Doe, Councilmember from Ward 1, and Councilmember Charles Allen from Ward 6. We will also be joined by Councilmember Zachary Parker from Ward 5, but we currently do have a quorum for the committee to move forward. Today, we will consider and vote on 9 measures before the committee, 7 confirmation resolutions, and 2 permanent bills. So buckle up. I'm going to do this as quickly as I can. Our first nomination is for the Board of Pharmacy. PR 25-999 nominates Dr. Jamila Jordan for an appointment to the Board of Pharmacy for a term to end March 12th, 2026. Dr. Jordan serves as the Director of Experiential Programs at the Howard University College of Pharmacy, where she oversees the practical experience component of the curriculum. Dr. Jordan is also an active member of several professional organizations, including the Washington, D.C. Pharmacy Association, the Washington Metropolitan Society of Health Systems Pharmacists, and the American Association of College of Pharmacy. Recently, she was elected the chair-elect of the experiential education section of the American Association of Colleges of Pharmacy. She holds a Doctor of Pharmacy degree from Howard University, and she is a Ward 5 resident. Been a really good discussion at her hearing, but I will now open up the floor for discussions on this nomination. Okay, hearing none, I now move the draft report in print for PR 25-999 in block with leave for staff to make any technical changes. All in favor, please say aye. Aye.
Aye.
Aye.
Let the record reflect that the ayes have it and the measures pass unanimously. We'll now move on to our nominee for the Board of Nursing. PR 25-1000 nominates Ronald Chaley Jr. to the Board of Nursing as a licensed nursing home administrator for a term to end July 21st, 2027. Mr. Chaley is an administrator of Inspire Rehabilitation and Health Center, a district-based skilled nursing facility. Previously, he served as an administrator at several Seva senior care locations in Maryland and the district. Mr. Chaley has more than 20 years of experience overseeing skilled nursing facilities, and he earned his Master's of Business Administration at Suffolk University. He is a Ward 2 resident. I just want to remind colleagues that when we took action on the Health Occupation Revision Amendment Act, that dissolved the previous Board of Long-Term Care and consolidated them with the Board of Nursing. And so Mr. Chaley will be taking the seat for the nursing under that. And with that, I open the floor to discussion on this nomination. All right, hearing none, I move the draft report in print of PR 25-1000 in block with leave for staff to make any technical changes. All in favor, please say aye. Aye.
Aye.
Aye.
Great. Let the record reflect that the ayes have it and those measures pass unanimously. The next three nominations will be for the Board of Medicine, and I will move those in block if there's no objection. Okay. PR 25-1001 nominates Anasia Phillips to the Board of Medicine for a term to end August 3rd, 2025. Ms. Phillips currently serves as a legal assistant with Ice Miller LLP. She brings prior experience from her role as an administrative assistant to the State of Tennessee Board Medical Board, where she reviewed health professional applications. Ms. Phillips holds a bachelor's from Wyoming State University. She's a Ward 8 resident, and she would be taking the consumer seat on the Board of Medicine. PR 25-1002 nominates Dr. Bernard Ahrens to the Board of Medicine for a term to end August 3rd, 2025. Dr. Ahrens is a psychiatrist and behavioral health expert who has contributed significantly to mental health policy, both at the federal and local level. He currently serves as the behavioral health medical director with Amer Group DC. Previously, Dr. Ahrens was the director of medical affairs at St. Elizabeth's Hospital. He also led initiatives with SAMHSA to advance mental health awareness and suicide prevention, and he is a Ward 3 resident. PR 25-1003 nominates Dr. Conrad Dawson for reappointment to the Board of Medicine for a term to end August 3rd, 2027. Dr. Dawson is the president and COO of Washington Area Plastic Surgery Associates with over 15 years of experience in private practice as a plastic surgeon. He is a member of the American Society of Plastic Surgeons and the Northeastern Society of Plastic Surgeons, and is a fellow of the American College of Surgeons. He also dedicates his time to helping cleft lip and palate repairs for underprivileged children abroad. He's a Ward 4 resident. I'll just mention we held a hearing on all three nominations. We have a very interesting conversation and discussion around, at least for Dr. Dawson, who is a reappointment, around some things that he wants to see changed on his next tour of duty and serving on the board, particularly as it pertains to investigations of disciplinary issues. For Dr. Ahrens, and we talked a lot about mental health and sort of getting more folks into the profession. And then with Ms. Phillips, because she had previously worked for the State of Tennessee Medical Board, we talked about process and how, our number one complaint or concern that we get from our health professionals is how long it takes to get licenses renewed. And so that's something that she will be looking at in particularly. I will now open the floor for discussion on these nominations. Okay, hearing none, I now move the draft reports and prints for PR 25-1001, 1002, and 1003 in block with leave for staff to make any technical changes. All in favor, please say aye. Aye.
Aye.
Great. Let the record reflect that the ayes have it and those measures pass unanimously. All right. We're moving on to the Board of Professional Counseling. PR 25-1037 nominates Dr. Laura Golajuk to the Board of Professional Counseling as a licensed marriage and family therapist for a term to end July 1st, 2027. Ms. Golajuk practices couples and family therapy at the Counseling and Consulting on the Hill. She's also a clinical supervisor and provides supervision to therapists in training and is an adjunct professor at the University of Maryland. She earned her PhD in family science from the University of Maryland and is a Ward 1 resident. Ms. Golajuk will be the first marriage and family therapist appointed to the Board of Professional Counseling since a seat was created in the Health Occupation Revision Act, also known as the HORA. In that bill, just as a reminder for colleagues, we sunset the Board of Marriage and Family Therapy. Ms. Golajuk testified at the hearing that she's looking forward to better collaboration between the counseling professions and is exciting to sort of be the inaugural person to serve in this role. I now open the floor to discussion. All righty. Hearing none, I move the draft report in print for PR 25-1037 in block with leave for staff to make any technical changes. All in favor, please say aye. Aye.
Aye.
Aye.
Great. Let the record reflect that that measure passes unanimously. We'll now move on to our last nomination, which is for the Board of Dietetics and Nutrition. PR 25-1043 nominates Dr. Deanna Nara to the Board of Dietetics and Nutrition for a term to end March 12th, 2028. Dr. Nara is a senior policy associate with the Center for Science in the Public Interest, where she advocates for healthier food systems. Dr. Nara has written many journal articles and presented at conferences on a variety of issues surrounding integrative medicine and healthy living. She earned her PhD in nutritional sciences from Howard University and is a Ward 3 resident. I'm going to open the floor on this nomination. All right, hearing none, I move the draft report in print of PR 25-1043 in block with leave for staff to make any technical changes. All in favor, please say aye.
Aye.
Aye. Charles?
Aye.
Okay. Great. Let the record reflect that was unanimous. Okay, we're now moving on to our bills. So the first bill we're considering today is Bill 25-692, the Enhancing Mental Health Crisis Support and Hospitalization Amendment Act of 2024. This bill was introduced on February 5th by myself, Councilmembers Joe Parker Bonds. Bill 25-692 aims to improve the district's processes for involuntary hospitalization. This legislation also aims to provide health professionals, residents, and the courts with clearer and more transparent policies and comprehensive resources. Involuntary hospitalization, also known as civil commitment, authorizes the detention of individuals in psychiatric facilities for evaluation and treatment without their consent when they pose an immediate risk to themselves or others due to severe mental health condition. This process is an essential emergency intervention, ensuring timely care for those in crisis. Unfortunately, certain aspects of the district's crisis response and civil commitment system is plagued by significant challenges, including understaffing, a lack of transparency in decision-making processes, and inadequate resources to provide timely and effective treatment to individuals who are in need. Over the past 9 months, my staff and I have been engaged with behavioral health providers, advocates, hospitals, and government agencies such as the Department of Behavioral Health, the Public Defender Service, the U.S. Attorney's Office, and the Office of the Attorney General to craft a balanced approach focused on patient safety, rights, and timely care. We deeply appreciate the contributions of those who testified at the July 11th public hearing and took the time to meet with us throughout this process. I want to take the time to describe some key provisions in the committee print, which are different in some cases from the introduced version of the bill. First, the committee print expands the role of the psychiatric mental health nurse practitioners by authorizing them to initiate involuntary commitment, serve as witnesses in proceedings, and participate in other crucial mental health related activities. These advanced practice registered nurses possess specialized training in mental health and assessment and treatment. This expansion aims to improve timely intervention by increasing the pool of qualified professionals involved in the process. Second, the committee print removes the provision extending the emergency observation and diagnosis period from 7 to 15 days in response to concerns that longer detention period could result in unnecessarily prolonged stays, potentially worsening patients' conditions and leading to negative outcomes. The committee print also revises the provision in the introduced bill extending the probable cause hearing or the PC hearing timelines from 24 to 72 hours, with a restriction against holding PC hearings in the first 24 hours of a request. The committee print extends the time frame to 48 hours while removing the prohibition on a hearing occurring sooner if feasible. This adjustment provides essential due process protections while allowing courts and hospital staff an additional day to prepare while preserving the flexibility to conduct hearings within 24 hours if necessary. The committee print also extends this timeframe for probable cause hearings under the Incompetent Defendants Criminal Commitment Act from 24 to 48 hours to align the timeline under the standard FD12 process. Third, the introduced bill prioritized virtual hearings, while the committee print has removed this prioritization. While recognizing the concerns of some stakeholders about the potential disruption of the therapeutic environment caused by in-person hearings, the committee print prioritizes patients' rights to request an in-person attendance in court when their liberty is at stake. According to the Public Defender Service in 2023, only 9% of the 2,905 FD12 cases led to requests for a probable cause hearing, and of these, only 131 patients requested in-person hearings, and just 8 were ultimately held in person. Courts currently allow parties to request remote participation, often granted due to staffing shortages, scheduling conflicts, or geographic limitations. The committee print does not alter the court's authority to permit remote participation for these reasons. Additionally, the committee print permits courts to grant continuances due to extreme weather conditions, security concerns, or patient medical conditions. It also allows consideration of alternative formats, including virtual hearings when transporting a patient poses a significant risk to the patient or others. This provision should respond to the hospital leaders' concerns about the risk involved in providing transport of patients who may pose safety risks to themselves, hospital staff, or others they may encounter. Additionally, the committee believes that extending the probable cause hearing timeframe from 24 to 48 hours will give hospital staff additional time to plan for absences and minimize disruptions in the therapeutic environment. Fourth, the committee print allows physicians to certify admissions at their own facilities to streamline emergency hospitalizations, provided their compensation is not admission dependent. This change, again, aims to expedite patient treatment by eliminating the redundant evaluations, reducing stress during the crisis point. Fifth, the committee print requires the Department of Behavioral Health to develop an online training for healthcare professionals and the public on the district's commitment process, enhancing system transparency and improving compliance and understanding while also trying to reduce stigma. Enhanced awareness of mental health laws will empower patients, caregivers, and treatment providers to make informed treatment decisions. Six, the committee print removes the provision in the introduced version that mandated treatment timelines for individuals deemed incompetent in criminal cases under the Incompetent Defendants Criminal Commitment Act of 2024. However, it extends the probable cause hearing deadline from 24 to 48 hours when a case has been transferred from criminal court to family court and a petition for civil commitment has been filed. This change, again, is trying to adjust the probable cause time frame for individuals entering the system through FD12 petitions. Lastly, the print removes the provision in the bill as introduced that would have empowered the court to issue warrants for individuals who fail to appear at hearings or comply with treatment orders, which is our aim to, which was aiming to enhance court enforcement mechanisms. I think that the committee print represents a thoughtful update to the district's mental health intervention and hospitalization processes, prioritizing rapid access to care while safeguarding patient rights. And I now open the floor for any comments from members on Bill 25-692. Thank you for the opportunity to sort of go through all of that. Councilmember Allen.
Thanks, Councilmember Henderson. I first off want to thank what is clearly a lot of work done by you on this bill. You touched on it a good bit, but I just want to make sure I kind of ask the question so you have a chance to kind of make sure you're addressing it directly. We did hear from, I believe it was the DC Hospital Association or some of the hospitals concerned about the in-person probable cause hearing. And if I understood most of the concerns correctly, it was related to perhaps costs involved with staff that would need to be transported to an in-person probable cause hearing, potential disruption that would cause. I think you walked through what you believe to be the numbers from PDS about the number of actual times it's used. So my assumption is that you believe it won't get used that often in practice. But I want to make sure I give you the chance to kind of outline why you think the Hospital Association's concerns may not be warranted and why you think this is the right way to go.
Thanks for that question, Councilmember Allen. So, I reviewed the letter we received from the Hospital Association. And of course, we've had a number of conversations with them throughout this particular process. As I mentioned from the numbers in terms of the number of individuals who, number one, request an in-person, and then that is also granted, we're not talking about a large number of individuals. So I feel like we have struck the right balance here in terms of allowing the courts flexibility to continue to do the processes that they have been doing. I think there might be some concern, although we haven't seen this happen yet, that a lot of these changes around virtual hearings, of course, happened during the pandemic and they have continued on. I think there might be some feelings that the court might somehow pull back on that, but we don't anticipate that happening, especially since when there have been staffing concerns or other things that were raised, the courts have been already willing to accommodate hospitals by doing a virtual hearing instead. I think in a conversation I had with some of the staff at PDS, which I think is kind of important here to realize, right? There are multiple parties involved in an involuntary hospitalization situation. But if we are to desire for someone to actually commit to the treatment plans that are being proposed by their medical providers, in some ways, we also need to feel as though they felt like they have been heard. And for a lot of individuals, or for some individuals, they want their day in court. And for us to outright deny that simply due to a technical logistics of a hospital, we didn't feel like we were prepared to make that step. And so I feel like what we have here is a good balance.
Okay, thank you very much.
Thank you. Any others? Okay. I can't see in the room on my computer. And so I'm not sure if Councilmember Parker has joined us, but I do know that this bill was important to him. So I wanted to give him a minute if he was here.
No, he has not joined.
Okay. All right. Well, I guess that is what the Committee of the Whole and the legislative meetings are for. All right. I will move the draft report and print for Bill 25-692 in block with staff to make any technical changes. All in favor, please say aye. Aye.
Aye.
Great. Let the record reflect that the ayes have it and that measure passes unanimously. Our final bill today is Bill 25-696, which is the Insurance Regulation Amendment Act of 2024. As was sort of alluded to earlier, we were waiting on one committee to vote, and so I think we're clear now to vote on this as well. So Bill 25-696 was originally introduced as the Advancing the Range of Reproductive Options for Washingtonians Act of 2024, or ARROW, on February 14th, 2024 by myself, Councilmembers Bonds, Louis George, Nadeau, and Pinto, to require health insurance plans to cover vasectomies at no cost to the patient. The bill was jointly referred to the Committee on Business and Economic Development, as well as the Committee on Health. CBED just marked up the bill earlier this afternoon, and so we can now move forward. CBED incorporated into this legislation language from two related bills that was referred to their committee, but wasn't referred to ours. So I'm going to briefly describe everything. Well, I'm going to focus on the portions that are related to the Health Committee and then just give a brief explanation of the others, just in case somebody missed that previous markup. So the two bills that were incorporated were Bill 25-925, the Health Insurance Coverage Expansion Amendment Act of 2024, and Bill 25-926, the Medical Malpractice Clarification Amendment Act of 2024. Taken together, this consolidated bill makes some significant advances in improving access to reproductive health care and protecting medical professionals' right to provide appropriate health care. To reflect on the scope of the committee print, the bill as a whole has been renamed to the Insurance Regulation Amendment Act of 2024. And I'm going to describe a couple of key provisions. The committee print requires health insurance plans to cover vasectomies at no cost to the patient. Vasectomies are one of the safest and most effective kinds of birth control, yet it is very underutilized here in the United States. However, since the Dobbs decision, the district has seen an increased interest in this procedure. Planned Parenthood of Metropolitan Washington saw such a significant increase in vasectomy requests that they started a new practice focused on the service. The print provides religious exemptions and exempts enrollees of high deductible health plans to align with federal requirements, and there are several significant changes from the bill as introduced. First, vasectomies are already covered as a service under DC Medicaid, so the committee removed the specific mention of Medicaid here. So I don't want folks to get confused to say that we took that out, but it's already covered. Second, the committee print clarifies language in the code requiring Medicaid and DC Healthcare Alliance to cover voluntary sterilizations for only women to include coverage for all voluntary sterilizations to reflect the coverage that already exists. Third, the committee print requires private insurers to cover all voluntary sterilization procedures and services instead of just vasectomies. So this is a bit of an expansion. And then finally, the print does not include any language in the bill as introduced regarding prior authorization, because this was already covered by Bill 25-124, the Prior Authorization Reform Amendment Act of 2023, which the committee marked up last year and is now currently law. The committee print, as I mentioned, includes provisions from Bill 25-925, which requires private insurers to cover the cost of certain reproductive health care services without cost sharing. This bill will ensure that their cost is not a barrier to care. The committee print also includes provisions from Bill 25-926, which prohibits medical malpractice insurers and medical professional liability insurers from taking adverse actions, including refusing to issue or renew a policy or imposing any sanctions or fines based on the provision of a certain legal health care or reproductive care services offered in the district. I want to thank Councilmember McDuffie and the CBED staff for their collaboration on this legislation. I also want to recognize Councilmember Robert White and his team for their hard work on two of the bills that were incorporated into this print. And also, I want to thank everyone who testified at these hearings on these three pieces of legislation. I also want to note that the OCFO reports that there is no fiscal impact for this bill, which, thank God, that's rare. And so I want to open up the floor to any discussion on Bill 25-696. Charles?
Thanks, Councilor. I just had one question. I hope it's just more of a clarification. When we look at and kind of focus on the medical malpractice part of this, I just want to be clear that this would not apply if an adverse action is a result of actual medical malpractice during a procedure or care that's provided, correct?
Correct.
Okay, thank you. Just want to make sure that's clear. Appreciate it.
No problem. All right. Any other comments? Okay. Hearing none, I move the draft report in committee print for Bill 25-696 in block with leave for staff to make any technical changes. All in favor, please say aye.
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 Great. The ayes have it unanimously. So this concludes today's committee meeting. This is the last committee meeting of Council Period 26, where we will consider permanent legislation. There will be one more committee meeting in December to vote on the committee's end of year report, as well as one last group of board nominations. With no further business before the committee, the time is 3:02 p.m. and this meeting is adjourned. Thank you guys so much.
Thanks.